Morning. I'm Tim Sheehy, president of the Metropolitan Milwaukee Association of Commerce. Our mission is to develop this region as a globally competitive location for businesses supporting high-value employment to foster a vibrant quality of life for all. This program is designed to provide actionable insights into the challenges and opportunities we all face in bettering the region as a place to live, work, play, and learn. Our next webcast will be Tuesday, November 3rd from 11 to 12. The program is sponsored by United Healthcare. In times like these, a traditional healthcare plan may not be the best fit for your business. So take a closer look at the All Savers alternate funding from United Healthcare. MMAC has partnered with United Healthcare to offer coverage for groups with between 5 and 99 employees. Now, small businesses can take advantage of the benefits typically reserved for larger companies, including underwriting for more competitive pricing, better data so your business understands where your premium dollars are going, and a potential surplus refund if claims are lower than expected. So contact your MMAC broker or visit uhc.com/MMAC to learn more. And a thank you to Spaces, which is serving as our temporary home during our office relocation. Over 3,000 global locations and 10 in Wisconsin, Spaces makes it easy to have a productive day at work. And a final program note, join us for a presentation with nationally renowned economist Brian Ballou on October 28th. His insights will help your business prosper during uncertainty. Now for today's program. Over the next 4 webcasts, we're going to unpack the challenges and explore the opportunities facing the region as we recover from the pandemic. What changes can we expect to stick with us? What innovations will become the new normal? And how can we better compete for capital investment and jobs? We're going to focus on 4 aspects of the region's quality of life. How will our built infrastructure develop from COVID's impact? How will the work environment change both in and outside the office? How will our entertainment options be impacted? And how will they affect the way we learn? So in short, what will happen to our live, work, play, and learn value proposition as a region? Today's program will focus on how some of our key learning institutions and how they've been impacted and what lies ahead. We're grateful that UWM Chancellor Mark Money, Marquette University President Mike Lovell, and METC President Vicki Martin have joined us to share their insights. So let's get started with an update from another learning leader, Dr. John Raymond, President of the Medical College of Wisconsin, who will again provide us with an update on the healthcare impact and status of COVID. After Dr. Raymond's update, we'll take a few questions and then we'll get to our distinguished panel. Dr. Raymond, thank you again for joining us.
Thank you, Tim, and good morning and hello, everyone. I hope that you're all well. It's an honor to be here today on this webinar with Drs. Money, Lovell, and Martin. Mark, Mike, and Vicki, each of you is an outstanding colleague and leader, and we're fortunate to have you in the region. If I could go to the first slide, please. As many of you know, Wisconsin is an epicenter of COVID-19 in the US and has been for over 2 weeks. And according to the New York Times COVID-19 Metro Tracker, as of yesterday, we still had 5 of the top 9 and 8 of the top 20 metro areas in terms of new cases per 100,000 population over the last 2 weeks. And those are Oshkosh, Neenah, Appleton, Sheboygan, Wausau West and Green Bay, Fond du Lac, Manitowoc, and Beaver Dam. Platteville and Marinette have fallen out of the top 20. So we still have 8 of the 20 worst metro areas in terms of burden of COVID-19 disease. And looking forward, only one Wisconsin metro area, Sheboygan, is rated as having the fastest rises in COVID-19 cases, although nearby, Marquette, Michigan is also on the list. So let's go to the next slide, please, and start with a summary of testing data. Cumulatively, we have tested 1.9 million people in Wisconsin as of yesterday, with just over 300,000 of those being tested in Milwaukee. So we've had 174,000 positive tests in Wisconsin, positive cases in Wisconsin, and 35,000 in Milwaukee. And we've been increasing by about 3,000 cases per day in Wisconsin over the last week. Now, the number of people tested who were reported over the last 3 days in Wisconsin averaged about 14,000 per day. Now, I do want to draw a distinction about tests administered and people to whom tests have been administered. We usually have about twice as many tests reported as people tested. So on average, it appears that many people are being tested more than once. And this occurs for a variety of reasons, such as frequent testing in congregate living situations, schools, and frontline healthcare settings. And some people also are tested multiple times because of severe symptoms or to confirm resolution of viral shedding. Now, reporting of cases rather than tests is the most appropriate public health metric. However, DHS now reports both, as well as positivity rates using cases or tests reported. Our testing capacity has remained stable at about 42,000, with 117 laboratories now testing. If I could shift to the right side of the slide, daily positive tests have been trending unfavorably in Wisconsin over the last month. And yesterday, there was a new high of 3,777 new cases reported in Wisconsin and 493 in Milwaukee. That was the second highest day in Milwaukee. DHS did warn us, though, that there's a backlog of cases yet to be counted, so we should expect continuing high daily case counts for the next few days. And just to put this in perspective, we've exceeded 2,000 new COVID-19 cases 28 times and 3,000 7 times over the last 26 days since we first exceeded 2,000 on September 16th. Now we're averaging almost 3,100 cases per day now. That's 4 times what we were seeing in early September in terms of daily cases. Now, our average case positivity rate over the last 7 days in Wisconsin and Milwaukee were 21.1 and 8.1% respectively. Now, these are too high and suggest that there remains a significant burden of undiagnosed COVID-19 cases, both in the state and in the Milwaukee area. Now, I do note that the Milwaukee positivity rate is trending favorably, and this is most likely due to a significant increase in testing here in southeastern Wisconsin over the last 2 weeks. And I would point out that we have opened a new high-capacity testing site at Miller Park, and this is a step in the right direction. Next slide, please. This next slide shows various indicators of hospitalizations. Now, we've had 9,319 admissions with COVID-19 to Wisconsin hospitals since the beginning of the pandemic. And as of yesterday, we had a new high of 1,172 patients in Wisconsin hospitals who have COVID-19. This is a week-over-week increase of 222 patients. There's also a similar trend with COVID-19 ICU admissions. Wisconsin reached a new high census of 302 yesterday, with a week-over-week increase of 62. ICU bed availability dropped significantly in early October, but has been stable over the weekend. So there were 231 beds available yesterday, which compares to counts of close to 400 every day in August. Now, our ventilator capacity is copious, and this should not be a limiting factor for caring for COVID-19 and other patients as we look forward. PPE supplies also have improved, but the supply chain remains fragile and we can't take it for granted. Next slide, please. This just dives down a little bit more deeply in the data about where in the state we're experiencing increases in hospitalizations. And to start with, hospitalizations are rising in all 7 of the Healthcare Emergency Readiness Coalition regions. And COVID-19 hospitalizations are at or near all-time highs for all of the HERC regions. And you can see the numbers of hospitalizations listed on the slide there. COVID-19 ICU admissions are rising or peaking in 5 of the 7 Healthcare Emergency Readiness Coalition regions. And COVID-19 ICU admissions are at or near all-time highs for those regions as well: Fox Valley, Northeast, Northwest, South Central, and Western. And ICU censuses are high in 6 healthcare readiness coalition regions, and you can see they range from 79 to 93%. And ideally, you want your ICUs to be running anywhere between 65 and 70% occupancy. The efficiency degrades significantly as those percentages go up. Now, I do want to clarify that most of the patients in the ICUs do not have COVID-19, but a surge of COVID-19 patients requiring intensive care places a strain on our ability to take care of all of our patients. Indeed, the Madison area health systems are considering reductions in non-emergent care. This morning, there was a segment on CBS this morning about UW Health's flagship hospital in Madison being full and how that's impacting care there. Now, in terms of the southeastern HERC, which includes Milwaukee, we currently are experiencing a boomerang, or a resurgence of virus returning from the rural areas of the state into our region. And this started about a week ago. COVID-19 hospitalizations are rising and are now at an all-time high in our region, and ICU admissions are also rising. Next slide, please. Now, this slide is from the Wisconsin Hospital Association. These are screenshots from yesterday, and they show hospital and ICU trends since the beginning of the pandemic in Wisconsin on the left and in southeastern Wisconsin on the right. These graphs demonstrate the recent rapid increases of COVID-19 hospitalizations for Wisconsin and for southeastern Wisconsin, which, as I mentioned previously, are at all-time highs. They also show increased ICU utilization for COVID-19 patients at an all-time high for the state on the left and rapidly rising for southeastern Wisconsin. Now, I would point out that in Wisconsin, we're not alone in experiencing such a surge, as currently there are rising hospitalizations and ICU utilization in 37 of our 50 US states. Next slide, please. This slide shows that 78.7% of the patients diagnosed with COVID-19 in Wisconsin are categorized as recovered. Now, I do want to emphasize that means that they have cleared their virus, and does not mean that they have recuperated to their pre-COVID-19 state of health. Many of these patients are so-called long haulers who have symptoms weeks to months after their infection. We also have 20.3% of the cases that are diagnosed that are currently considered active, and that percentage is increasing as the numbers of daily cases continue to rise. 0.9% of patients diagnosed with COVID-19 have died in the state. And I think that's a testament to the high quality of care that we have here. Ultimately, when the pandemic is over, the infection fatality rate is likely to fall in at about 0.6 to 0.7%. That's 5 to 10 times higher than the mortality rate for the seasonal influenza. Now, we've had 1,600 cumulative deaths in Wisconsin and 454 here in Milwaukee. The daily number of deaths clearly is rising in Wisconsin and Milwaukee, but this is much more apparent in the aggregate Wisconsin numbers. I'd also point out that these deaths disproportionately affect people in communities of color, but COVID-19 can be fatal for anyone. And as you can see, that the majority of deaths in Wisconsin are among people who self-identify as white. And this is particularly important consideration in rural areas of the state. The doubling time for positive tests is trending unfavorably at 42.3 days in Wisconsin and 81.9 days in Milwaukee. The 7-day growth rate of positive tests is stable at 1.9% in Wisconsin and 1.2% in Milwaukee. Now, the reproductive number is 1.0 in Wisconsin and 0.95 in Milwaukee. Now, these numbers had been at or over 1 most of the days since the beginning of September. But I'd point out that we need them to drop significantly below 1.0 before we see the case counts drop. And as you know, if we have a reproductive number of 1.0 and already have a high burden of disease, it means we've stabilized at an unacceptably high plateau. And I'd also like to caveat that the R numbers today may be inconsistent because of delays in reporting from DHS over the past weekend, which corresponded to their upgrading their system. Next slide, please. Now on this slide, I just want to remind people of a framework for considering what you can do to minimize your risk for a COVID-19 infection. And these would include reducing the number of exposures you have to people. And remember, COVID-19 is most contagious in the 2 days before people develop symptoms, reducing the proximity of your interactions with other people, reducing the intensity of your exposure, meaning that you don't want to be indoors or around people that are singing, shouting, or speaking loudly, reduce the duration or length of your exposures. And these are all important concepts when you think about trying to reduce individual risk. If I could go to the next slide, I do want to talk about community risk and point out that community risk also affects your individual risk. So when you think about the community, the elements that add to the risk would include a higher population density, lower levels of population health, and these involve the social determinants of health, the number of interactions that we have in work settings, social settings, and family settings, pre-existing conditions in the population, and then the burden of COVID-19 in your region, which as we know is now high in Wisconsin. Next slide, please. This slide simply presents the concepts from the previous slide as an infographic. And again, community risk is based on 5 parameters: population density, population health, the number of interactions that people have in the population, pre-existing conditions in the population, and the overall burden of COVID-19 in your community at a given point in time. I think the most important takeaway from this slide and the previous slide is that the burden of disease and other community risk factors influence your individual risk. Next slide, please. Now, this next slide summarizes individual predisposition factors for COVID-19 that increase your risk: male gender, age over 60, obesity, race, and there's a higher risk if you're Black or African American, Native American, and some Asian race identities. Also ethnicity, Hispanic and Latinx populations are more susceptible to COVID-19. High ACE levels. ACE is the receptor that the virus uses to invade mucosal cells. And non-type O blood, as well as pre-existing conditions like kidney disease, heart disease, hypertension, diabetes, cancer, lung disease, COPD, asthma, autoimmune disorders, and immune dysfunction like people would have if they're on chemotherapy for cancer. Also, there's a growing awareness that low zinc and vitamin D levels might also be risk factors. So with this backdrop, I'd like to emphasize that the idea that we should simply sequester those at risk and allow everyone else to resume normal activities is not a simple nor an appropriate practical solution. If we decided to protect the elderly and those with pre-existing conditions, we need to protect half of the population, and clearly that's not practical. All of us need to participate in doing what we can to modify the spread of COVID-19. Next slide, please. There are also social factors that influence susceptibility to COVID-19, and these disproportionately affect people in communities of color, and they include zip code, neighborhood, healthcare access and utilization, occupation, educational level, income, wealth gaps, and housing. Next slide, please. I just want to highlight the data sources that we use at MCW to prepare these presentations. From time to time, we do use other data sources. And before the webinar is over, I do want to provide to you a link that talks a little bit more about the R value. It's a very nice and approachable paper that I thought might be useful to the audience. And with that, I'll turn it back over to Tim.
Thanks, Dr. Raymond. Some really a good presentation and some really challenging information. So, I've got a couple questions for you before we get to our panel. And the first one, I think, is just a continuation of the challenge we have in the state. And the first question really goes to lays out the question, look, if we have a statewide mask mandate and people are wearing masks, why are we continuing to see the spread?
Yeah, it's a good question. And again, everyone has to understand, mask is not a biohazard suit or a biocontainment suit. You're simply trying to minimize your risk. So wearing a mask is one element of reducing that risk. But I would counter the idea that everybody's wearing a mask. It's simply not true. You see many, many people out not wearing masks. So let's start right there. Adherence probably isn't optimal. And there are people that are interacting, especially in cold weather, inside homes, which we know right now is the major source of community spread. So it's, fourfold: reduce the intensity, the duration, the number, and the duration, the proximity of your interactions with other people. So you have to do more than one thing. And I also point out something that's a pet peeve of mine. Many public health officials inappropriately say, wear a mask when you can't socially distance. That's wrong. It's wear a mask, especially when you can't socially distance. A 6-foot distance does not substitute for wearing a mask.
The other question, and we've had this multiple times also, Dr. Raymond, that when the deaths are reported, that most of the deaths are what, a comorbidity, or there's some other factor. So somehow the system's being gamed and we're reporting deaths of people that have other factors attributable to that than they do the COVID.
First of all, I'd say most physicians have no interest in gaming the system. Physicians, not health systems, fill out the death certificate. And typically you put down all the potential causes of death. And what I would say is it's really not fair to say that if someone died of a heart attack or a stroke when they had COVID-19, that it wasn't due to COVID-19. We know that COVID-19 increases the likelihood of blood clotting. So I'm going to strongly refute those claims. Most of the folks that have taken care of COVID-19 understand it's a devastating disease that is the proximate cause of death in most of the people that have COVID-19. And I'll also say it's a value statement to just basically shrug your shoulders and say they had pre-existing conditions, they were going to die anyway. I don't buy that.
Should we all be tested on a regular basis?
Let me start by saying yes. On the other hand, one of the things we are not doing well in Europe and the US is contact tracing. People aren't cooperating necessarily with contact tracing, and our public health departments are overwhelmed sometimes, especially when you have a surge. I think what's different about how well Asia handled it compared to how we're doing in the Western world is really twofold: immediate early availability of testing and significantly better contact tracing.
Dr. Raymond, does the hospital and ICU capacity include the field hospital at State Fair Park, or is it just in the standard hospitals?
It's in the standard hospitals, but what I would point out is the alternate care facility is not really a hospital. It's more or less a step-down unit for people that are on their way to recuperation. They may need a couple of days of supervised care, intravenous medications, or oxygen. But these are all folks whose trajectory would suggest they're going to be home within 24 to 72 hours.
There's a question about whether or not a large number of the positive cases recently reported have been in correctional institutions, and shouldn't that be called out to get a better idea of community spread?
Yeah, and I think that's a fair comment. But we know since the beginning of the pandemic, somewhere between 35 and 45% of the cases typically occur either in nursing homes or in prisons, the congregate living situations, and that the rest of the burden, 55 to 65% of the patients, are out in the community.
And then the last question, we'll jump to our panel and then come back if we have time at the end. And you've talked a little bit about this before, Dr. Raymond, but a number of people that get COVID and recover still have some lasting impacts. Can you talk a little bit about those and whether they're age dependent?
Really good question. I don't believe that the long hauler syndrome or long COVID is age dependent. And that could just be bias of younger people being on social media talking about their own personal situations. But it gets back to what I said early on. Just because you're categorized as recovered doesn't necessarily mean that you've recuperated to your pre-COVID-19 infection state of health. And we're finding out more and more that people are having lingering side effects, even people that had relatively mild symptoms. And some of those are fairly debilitating, an inability think clearly, no motivation to get out of bed, somewhat like chronic fatigue syndrome.
Well, Dr. Raymond, again, thank you very much for the presentation and the Q&A, and I know you'll stick around with us.